Okay, so my talk is not at all theoretical. I mean, I've just made it so that we can how I do pedicle fixations to probably I'll be able to give practical points about this. So we start any surgery with a proper positioning. I mean, we have to do a preoperative planning, and it is not different while putting up percutaneous screws. So position your patient so that first and foremost your C-arm has a if you are using CM, it has a free view, because most of the time, sometimes this table mount would come in your way. And specifically, if you are doing a lumbar L5S1 and if you want to use a Ferguson or a tilted view, this kind of tables, might be a problem. So, make sure that you have positioned your patient properly and you are able to visualize all the levels very clearly before you begin even draping your patient so that, you can adjust the patient. Planning of incision is also very important, where you are going, where what pedicle screws you are going to use. All these things you will have to keep in mind. So this is just a representative image. I mean, if you look at the A type of figure, the pedicles are, I mean, oblique, but if your incision is not in a proper plane of the blue line, either it is too medial or too lateral, your pedicle entry and the muscle creep would push your needle away from the ideal path, and you may probably try to violate medial or a lateral border of the spine. Pedicle. Make sure that you have a dead AP, a true AP, and a true lateral view of your spine. And we say that it's an owl sign with two nicely looking owl with center point is the spinous process, and you have crisp, sharp end plate above the upper end plate of the vertebra. You are inserting the pedicle screw. Never accept this kind of hole in your vertebra while you are putting a pedicle screw, because sometimes if you are breaching inferior or superior margin of your pedicle, this oblique vertebra would not give a proper view. So skin incision, either if you using a single level incision, single level surgery, you might want to go with a stab wounds, or if you are doing a multi level, you can put large midline incision and just do a multiple facial incision, so that it's a better scar, better healing. Or you may go for multiple skin stab incisions also. Before we begin, you have to remember that pedicle anatomy, as Dr. Vikas and Apaji both has, I mean, very elaborately described. It's a cylinder. So you start at 3 o'clock of the cylinder and you target at 9 o'clock of the cylinder. So you have to go obliquely to from one end to the other end in the pedicle, so that you can get a maximum convergence of the screw and the pull-out strength can be increased significantly. Now you start at the 3 o'clock of the pedicle in AP view. Look at the all three views, which are visible here, where your needle would be. So when you start at 3 o'clock, your needle should be starting the pedicle in lateral, and if you look at the axial, it will also start entering the pedicle. When you reach middle of the pedicle, your needle into the lateral view also should reach in the middle of the pedicle. And when you just try to touch the medial border or a 9 o'clock position on the pedicle, your needle would be entering into the vertebral body. So this is the most ideal position of your body, and these three shoots are mandatory before you advance your needle into the vertebral body, to make sure that you have not violated the medial cortex of the pedicle. Now you have to keep in mind and study the pedicle anatomy beforehand before you go into putting your pedicle screw, because pedicle anatomy would be different at different levels, and not only that, it will be very different at the same vertebra as well. So if you look at this pedicle left side in L2, you can see that it's more or less straighter trajectory than the routine convergent trajectory. If you go for L3, the convergence would be better, and you see the entry point has moved slight lateral to get a proper trajectory for your pedicle screw, rather than in this L2 pedicle. Now these are the cuts of the same patient, so you have to keep in mind that entry also would change, the way you go in down the level, and you can achieve good convergence on the left side of the pedicle in L3. You look at the right pedicle of this same patient, the pedicle is not only thinner, pedicle is more vertically oriented than the left side of the pedicle. So you have to make sure that this pedicle might encompass a larger size of the screw, and you may want to put slightly lesser size of the screw in this if you are doing a very tight or a fixed position. Now, if you see the center, in L2, there will be no convergence of the pedicle. So don't always try to achieve convergence in your patient by looking at your preoperative images. In this, your left screw would appear converging, but right screw will not appear so convergent because of the peculiar pedicle anatomy. Now, this is L4 is the most ideal vertebra in this patient, where you can achieve convergence. More or less, entry point would be same, and you can do in a classical way. L5 in majority of the cases will have a very peculiar anatomy to put pedicle screws. If you look at this patient, the entry goes quite lateral if you want to put the longest size of the screw. If you start here and go straighter, you know, sooner you will start breaching the lateral cortex and you will end up putting a smaller screw in this patient, or your screw will protrude out of the anterior border and may endanger the vascular structure lying around L5S1 disc space. So always study your anatomy of your patient before you encompass or before you go for a percutaneous pedicle screw fixation. Once you have done, the basic steps remain same. You have to target your Jamshidi needle at your entry point under your fluoroscopic guidance, and you have to plan your skin incision accordingly. Once you put the skin incision, jab your needle inside to do a liberal facial release. Otherwise, fascia would start pushing your needle away from your ideal trajectory point. So ideal facial release or a liberal facial release is very much mandatory to put a proper angulated screw. This is just a representative image. How you start? You start at the 3 o'clock on the pedicle and target the 9 o'clock. Now, when you're doing a multi-level screw incision, I always try to mark all entry point or a lateral border or a 3 o'clock position of the pedicle screw and draw a line. Why? Because if you don't draw a line, when you are putting upper size or a lower size screw, sometimes your screw will be not in line, and later on when you want to put a rod, this not aligned screws will make it difficult to put the rod in a proper position. So when you have marked, your all incisions will be aligned, and more or less your needle and screw placement would become in line, and it will be easier to put your screws. Now, accessing the pedicle, you have a Jamshidi needle or a bone biopsy needle. There are two types of needle available. One is a beveled ended needle, and the other one is trocar ended needle. So both needle has its distinct advantages. So generally, most of the cases we use a beveled angled Jamshidi needle, because the bevel helps me to direct my needle in whatever direction I want. So if your bevel is turned towards inferior, this part is turned inferior, and your needle will, when you try to enter the pedicle, your needle will gradually go upward. So you can actually change direction while going inside the pedicle. While trocar tip is very important in sclerotic pedicles, a bevel tip would get stuck in a sclerotic pedicle, and this trocar tip will act like a drill when you rotate, and you can very easily cannulate a sclerotic pedicle. You may use different kind of a navigated needle or a needle with a neuromonitoring probe attached. Now, before we go further for putting our screws, I always put a liberal facial incision. I use my finger to palpate all the anatomies, create a space for your needle so that unnecessary muscle fibers are not damaged. One. Second, I unnecessarily don't perforate the facet capsule specifically of the adjacent level, because if you don't use this anatomy, you will keep on perforating your capsule, and which later on may end up having adjacent level problem. So I always try to feel all these bony landmarks which Dr. Vikas and Dr. Appaji described in thoracic and lumbar pedicle with my finger before I start putting my needle inside. I try to avoid hammering needle most of the time. I try to rotate and go gradually inside the pedicle, so that if it is an osteoporotic bone, needle doesn't just go sink inside the pedicle and endanger the vascular or a neurological structure. So I always try to rotate the needle gradually, unless it's a very sclerotic bone where I am not able to go, and then those cases I use trocar tip and may use a gentle tap of the hammer. So gradually advance your needle targeting 9 o'clock. Once you reach your base of the pedicle, more or less, you are safe that you have not breached lateral border of medial border of the pedicle. Once you have cannulated the pedicle, try to put a guide wire from the Jamshidi needle, and make sure that your needle never goes into anterior 1/3 of your vertebral body, because sometimes you may have damaged the anterior end plate and your wire would penetrate that anterior wall, and while drilling or while tapping the pedicle, your wire would advance and may endanger the aorta, vena cava, which lies just in front of it. So I always keep my needle in posterior middle half or a posterior 1/3, and then advance the threaded ended guide wire inside the pedicle. I always try to feel the anterior wall. See, your wire should hit anterior wall in lateral view. Otherwise, if your wire is stuck like this somewhere in between, that means your wire is touching the lateral border, anterolateral border of your vertebral body, and you have to try to make it more medial so that your wire reach to the anterior vertebral body, and that is the proper convergence or a proper length of the screw you can insert. So once that is done, you insert all the wires and then start tapping the screw. Once screws are tapped, you can tap the pedicle. Again, only tap the pedicle. Never try to tap your cancellous bones into the vertebral body. Once tapping is done, start putting the screw inside. Always make sure that your screw is entering into anterior one third of the vertebral body. Don't try to go too anterior unless you want a bicortical purchase of your spine. Once the rod is inserted, there are various ways by which you can put this rod. Classical was sextant, where you have to mate the male and female post together. That will align the tulip of the screw, and from a separate stab incision, you can railroad the rod into the tulip and then fix the screws. When you are using multi-level, now multi-level freehand techniques are also available. You can do compression and distraction also along with different techniques with different system. You can contour the rod now when you are putting a multi-level freehand longitude or similar systems when you are using, and you can attend to this multiple level cases. These are the small incisions which are there for a percutaneous pedicle screw fixation. This is just a small video. I'll just quickly go through the video of percutaneous pedicle screw. This is how I am putting. This was one of the sclerotic bone where I've used the Jamshidi needle to hammer, tap gently till the needle reaches into the bone. So once needle is gone, the other needle has been put. Once needle is there, I put a guide wire inside. You can see this in CEM, all 4 guide wires are there. Once guide wires are inserted, dilate over the guide wire to create a space for the tap. Once tapping is done, this is how we are tapping. I only tap the pedicle, never try to go beyond the pedicle. Once tapping is done, put the screw. So this is the wiper system where the rod goes from the same channel. You don't need a separate channel. Always keep under observation of IITV. Every 10 millimeter or so, around 10 turns, you have to check your IITV that your screw is advancing properly. It is not tenting or bending the wire, or your wire is not migrating anteriorly. Sometimes when your wire is stuck inside the screw and you keep on rotating without checking the position of the wire will penetrate the anterior cortex, and it will start hitting on the vascular structure just lying in front of it. So once your screws are inside, you can use your technique, the system which is provided, to put your rod inside. And once rod is there inside, you can use compression distraction for your patient. So this is the final placement of the rod. So you can put the same things up on the opposite side, similar way, and you put the rod from the same incision. Thank you so much.